What are torch infection? Infection which can transfer from pregnant woman to baby. Torch includes toxoplasmosis, others, syphilis, Zika, Pravo B19, rubella, CMV, herpes simplex. Secondary torch infection and e.g. latent infection reactivation during preg, e.g., syphilis, CMV. Manifestation of primary torch infection. Antenatal, IUGR, IUD, preterm, abort. Postnatal, bone marrow suppression, anemia, thrombocytopenia, hepatosplenomegaly, lymphadenopathy, jaundice. Congenital rubella syndrome triad. Heart defect PDA, PS, VSD. Cataract, SNHL, MC. CRS. Other features apart from triad. 1. Salt and pepper retinopathy, black and white spots on retina. 2. Blueberry muffin lesion. In severe CRS, purpuric spots, dome-shaped papule, but not specific. Chronic manifestation of CRS. 1. PRP, progressive rubella panencephalitis. 2. Adult-onset diabetes. 3. Hypothyroidism. Diagnosis of CRS. Fetal IgM antibody against rubella, cause IgM can't cross placenta. Most common torch infection. CMV. CMV transmission trimester. In 90% cases, third trimester kid asymptomatic. In 10%, first trimester congenital diseases. Triad and other clinical features in CMV. Triad microcephaly plus chorioretinitis plus intracranial calcification. SNHL. Blueberry muffin lesion. Hepatosplenomegaly. Diagnosis of CMV. IOC PCR testing urine greater than blood. IgM AB against CMV. Treatment of CMV. Ganciclovir, IV 6 weeks then oral 6 months. Congenital toxoplasmosis trimester risk. Highest in third trimester. Triad and features of toxoplasmosis. Triad hydrocephalus plus chorioretinitis plus intracranial calcification. Low IQ, SNHL, microcephaly in some. Difference between intracranial calcification in CMV and toxoplasmosis. In CMV, paraventricular calcification. In toxoplasmosis, diffuse calcification. MC cause of non-syndromic hearing loss in children. Congenital CMV. Diagnosis of congenital toxoplasmosis. IgM-IgA ELISA. ISAGA immunosorbent agglutination assay. PCR in CSF. Treatment of congenital toxoplasmosis. Pyrimethamine plus sulfadiazine 1 year. Spiromycin to mother. Congenital varicella syndrome period of transmission. Second trimester 13 to 20 week of gestation. Clinical features of congenital varicella syndrome. 1. Cerebral atrophy. 2. Microcephaly. 3. Limb hypoplasia. 4. Cicatrix. Perinatal varicella. More common than congenital. 5 days before to 2 days after delivery. Acyclovir drug. Congenital syphilis time of transmission risk. Greater than 4 months of gestation. First, second, third feature of congenital syphilis. First, rhinitis, snuffles. Second, pemphigus syphiliticus, vesiculobolus rash on palm and sole. Third, bone pain, edema of affected limb, pseudoparalysis. Late onset features of congenital syphilis. After 2 years. 1. Hutchinson triad, SNHL, interstitial keratitis, peg-shaped incisors. 2. Mulberry molars, irregular. 3. Deformed nose. 4. Raygaud's fissure around mouth nose. 5. Sabre shin, blowing of tibia. 6. Clutton joint B, L-knee effusion. Diagnosis of congenital syphilis. VDRL, increased titers 4-fold. Treatment of congenital syphilis. Penicillin. Congenital Zika infection vector and period of risk. Aedes aegypti, first trimester. Recurrent abortions are features of which infection? Congenital syphilis. Clinical features of congenital Zika. Skull manifestation, limb manifestation, eye manifestation, ear manifestation. Skull manifestation of congenital Zika virus infection. 1. Partial collapse of skull. 2. Overlapping of sutures. 3. Microcephaly. 4. Chorea, athetosis. 5. Basal ganglia damgae. 6. Occipital prominence. Limb manifestation of arthrogryposis multiplex congenita, abnormally curved limbs. Eye manifestation of congenital Zika. Coloboma, pigmental retinal mottling, scars in macula. Ear manifestation of congenital Zika. SNHL. Congenital B19 parvo infection time. All trimester, most sensitive second. Congenital parvo B19 affect which RBC precursor? Prenormoblast. Clinical features of congenital parvo B19. Severe anemia, myocarditis, fetal cardiac arrest (IUD), non-immune hydrops fetalis.